So in my talk, I was actually going through all of the drugs that are licensed for MS and NMOSD, but I think for the sake of time, I will focus on those who actually have some potential, either based on published case series already or theoretically on the mechanism of action. So one very promising group is definitely anti-CD20 antibodies, so therapies that are directed against B cells. And rituximab, which is actually not licensed for MS or NMOSD, but is used across Europe and the United States for these conditions, has also been used for several autoimmune neuropathies, including CIDP. And it probably has the largest potential to actually be successful. The mechanism, as I said, is anti-B cell therapy. So it works against all the B cells that have CD20 expressed on their surfaces. So the cells that are stem cells and the plasmocytes are intact, and that's why the cells will repopulate after the treatment, and the immunity that has been acquired before treatment is intact as well. So it's a very good mechanism of action. The other drugs that are probably worth mentioning here are complement inhibitors, and that has nothing to do with MS treatment, but eculizumab and ravulizumab have both been registered for NMOSD and are especially efficacious for this disorder if it's an aquaporin 4 antibody positive disorder. So the complement has an important role in CIDP too. It has been found on pathology slides, and it has been validated in animal models too. So we know that complement deposition plays a role, and cases published again in multiple autoimmune neuropathies have proved successful. I think clinical trials will probably give us a definite answer, but that's definitely a good way to go too. And finally, from drugs that have not been so much yet tested for CIDP, but I think theoretically have a very good potential, is Cladribine, oral Cladribine, that is an immune reconstitution therapy for multiple sclerosis, has not been tested for CIDP, but the potential of a therapy that is given in pulses works predominantly on B cells, a little bit less on T cells, causing depletion, then repopulation, and after 2 cycles of treatment, 1 year after another, it causes also immune reconstitution, meaning that the immune phenotype does change, even with regards to cells that are not directly affected by Cladribine, like macrophages. So I think it's a very interesting mechanism, given that for CIDP, we do have effective treatments, and 80% of patients actually respond to the treatments that are in first-line use. But there are still some aggressive cases or non-responders, or patients who become dependent on frequent dosing of IVIG, which becomes expensive. So it really would be worthwhile considering a therapy that would work in the long term, but would be given only twice in a patient lifetime. So I think it's an especially attractive candidate.